Hello. We're going to do a review of the new Sapphire IV pumps. We're going to go over the pump general operations, so basic housekeeping items such as how to load the IV tubing, how to prime the pumps, and then we're going to look at some of the medications that we're going to infuse through the pumps and the clinical scenarios that we might use them in. You'll notice that the Sapphire IV pump is a single channel IV pump as opposed to the dual channel IV pumps that we had before. I think you'll find, though, that the ease of use of the Sapphire far outweighs the advantage of having a second channel. We're going to have one pump with each set of ALS gear, and the spare ALS gear at Airville will have an IV pump. So if you find yourself in need of doing two simultaneous drips, which we've done very few times, you could always stop at Airville and get the other pump if you're already traveling past Airville en route to the hospital. Or if you have another ALS unit on scene, you have the second MICU's there, you can certainly take their IV pump and they can go down to Airville and grab the spare pump. A few basic housekeeping items with the Sapphire pumps. When you want to charge them, the charging port is on the bottom. The chargers are in the critical box. You should not have to worry about charging the IV pump during patient care as long as you've made sure the pump is charged when you're doing your unit check at the start of your shift. The battery life is quite long. The second thing to watch out for is there's a cradle that the IV pump clips into. It's got a mount that hooks to the IV pole. It's got a nice feature that you can orient the pump in any direction. But if you're going to do that, make sure that you pull the two parts of the mount apart when you rotate them. If not, you'll see that it has teeth in there. If you don't pull the two apart all the way and you try to twist it too forcefully, you'll break the teeth off in the mount. The tubing, different from the other tubing we had, it looks a lot like regular IV tubing. It's got the drip chamber, it's got the roller clamp. The defining characteristic of this IV tubing is that there is this white cassette in the middle of the tubing. When we want to load the IV tubing, we're going to hook it up to our bag. We're going to squeeze the drip chamber, all that stuff we do when we're setting up regular IV tubing. And then we're going to come over, we're going to open the side door of the pump. We're going to look at the bottom of the cassette, and there's these two little grooves that line up with the two notches at the bottom. And we're just going to align those up and push it in. You'll see there's this little flange at the bottom of the tubing that keeps getting stuck every time I try to close the door. And you just got to pull it down a little bit and make sure that the flange there is resting underneath that white piece. Otherwise, the door won't close. If the door won't close, you can't start the IV pump. Removing the tubing, when we're all done, we want to take the tubing out. We just open the door again. There's these two little metal teeth there. You just lift them up and the tubing will pop right out. To prime the pump, there's one of two ways you can prime the tubing. You can either do it through the IV pump or you can do it manually. We're just going to show you how to do it through the IV pump in this video. That's the preferred method of doing it. We can make another video on how to prime it manually, or it's fairly simplistic to figure out, except there is a few intricacies of it. We find that there's less air bubbles, there's less issues with air in line, and if you've used the IV pumps before, you know that air is a sworn enemy of IV pumps. And if you start getting air in line alarms, that can take your peaceful transport to a very musical, unfun transport very quickly. So we recommend using the IV pump to prime your tubing. After you have it set up, you've spiked your drip set, you've filled up your drip chamber, you're going to put the cassette in, and you can click prime. It's going to warn you to disconnect the tubing from the patient before you prime the IV pump. Make sure you haven't hooked the tubing up to the patient because you're going to take all the air in the tubing and just infuse it into the patient. The priming will take 2 minutes if you go by the IV pump. It'll start out with 2 minutes, and I believe it's a 30 ml prime, which is a lot more fluid than we need to prime for the drip sets that we have. So once you see that your tubing's all primed, that you have no air bubbles and you have fluid coming out of the end that would hook into the patient, you can simply press finish prime and you'll get this screen here. A few things to take into consideration when you're priming your tubing is if you're setting up an infusion, you're setting up an epinephrine infusion, and you're going to have the pump prime the tubing. It's going to waste about, you're going to let it run the full 2 minutes. You're going to waste 20 mLs out of your 500 bag. You're still running a continuous infusion. The concentration's the same. It's not going to have any impact on patient care. However, if we have a different clinical scenario and we're giving magnesium to an asthmatic, we've taken 2 grams of mag, we've put it into a 100 bag, we hook that up and we tell the pump to prime it, and the pump primes 20 mLs out of the tubing, you've lost nearly a fifth of your medication. So keep that in mind when you're looking at when you're going to prime your pump, when you're going to add your medication in. And if you're going to do that, for example, with the magnesium, you'd want to be watching that very closely. As soon as your tubing is filled with liquid, you want to stop the prime. You don't want to let the full prime run, because then you're going to lose your medication. These pumps can be used in the hospital setting as PCA pumps. They can be used as epidural pumps. Lots of times that you don't want the patient getting access to the pump. It's really not a problem for us, except that same nice feature that prevents the patients from being able to access their pump and crank up their PCA pump also will lock the medics out from being able to adjust anything on the pump. What it has is there are 2 screen lock features shown here. You'll see if you press lock screen, the top lock screen would simply just lock the pump. You press a button. You don't want to hit it when you're carrying a patient in the house. Is a great feature to use. The bottom button will lock out the pump, and you need a password to get back in. The passwords are all taped to the top of the pump, 7770, or you get you back in. You might ask, why did we not choose a nice convenient number like 9595? Well, it turns out the 7770 is a default password, but any password you want to change it to, it has to start with the number 7. It has to be 4 digits, and all 4 digits cannot be the same number. So, unfortunately, we're stuck with 7770. Alright, I want to talk for a minute about doing IV drips, IV infusions versus doing boluses of medication with the IV pump. These seem similar, but there's actually a clear delineation we need to make between what is a IV drip and what is in a bolus of medication that we want to administer, and we're going to use the IV pump to help make it the safest and most efficient way we can administer it. So if we look at this list, medications that we would give as a bolus of medication, and I want to preface this with, this is for our pre-hospital use. People that do critical care transport might look at this and say, well, yeah, we give, we transport, preeclamptic patients on magnesium infusions. For our use in the pre-hospital setting, we're going to look at certain medications we're going to be giving as a bolus versus we're going to be giving as a drip. So lidocaine, for example, I'm not talking about the pre-filled, we're only talking about medications we're giving through the pump right now. Lidocaine, we have that big bag of lidocaine. All right, there would never be an appropriate time to decide to give our patient a nice quick bolus of lidocaine out of that big bag of lidocaine that we hang. So lidocaine would always be given as a drip, as an infusion. We're going to hang a big bag with a lot of medication, and we're going to give little bits of it over a longer period of time. Nitroglycerin, we have that glass bottle of nitroglycerin. We're never going to take that bottle of nitroglycerin. We're not going to be like, all right, let's just give this patient a big bolus of nitroglycerin. Hint, hint, that's to say we're not doing the boluses of nitroglycerin that the protocols have listed. The intent of that was to draw up the medication out of the bottle into a syringe and push it IV. Because we have the pumps, we're not going to be doing that. But we're going to look at some of the other medications that we might be giving as a bolus. For example, if we have magnesium, we want to give mag to a asthmatic. We're going to take that mag, we're going to draw up 2 grams of that mag, probably put it in a 100 bag, and we're going to run it in over 10 minutes. We can certainly do that through the pump. Just because we're giving the magnesium through the IV pump does not mean that we're giving a magnesium drip or a magnesium infusion. We're simply taking a bolus of medication, which we could have done by hand, but we're saying that instead of giving it over 20 minutes slowly, we want to free up the medic to do other things. We want to give it in a more controlled and safer manner, so we're going to let the pump drip it in. Another example would be D10. You have a pediatric patient that is hypoglycemic. You want to give them D10. You got this big bag of 250 mLs of D10. You need to get a small quantity out of it. You can pull it up in a bunch of syringes, but you know what? We have IV pumps. Let's just do it the easier way and run our D10 in, over 10 minutes. That's going to be, even though the medication is dripping in through an IV pump, that's still a bolus of medication. That's not a D10 infusion or a D10 drip. It gets a little bit more hairy when we start talking about cardizem and amiodarone, because we do both cardizem and amio as boluses and infusions through the IV pump. So, for example, when we look at cardizem, we can do our, everybody knows about our boluses of cardizem. We have our patient in AFib with rapid RVR. We get a command order to give this patient 10 milligrams of cardizem. We would give that through the pump. The pump, that's still a bolus of medication. That's not a drip. If we also get an order to put our patient on a 5 milligram an hour drip of cardizem, that's going to be the infusion. Amiodarone, for example, we can do if we have a patient who has VTAC with a pulse and we want to give them 150 milligrams of amiodarone over 10 minutes, we might use the pump to do that. We might take our amio, put it in a 100 bag, tell the pump to give this bag over 10 minutes. And we can certainly do that. That's still not an amio drip. That's still a bolus of amiodarone. That's not a drip. That's not an infusion. When we start talking about our amiodarone drip, that's when we might have a situation where our patient was in cardiac arrest. We got ROSC, and now we want to, we gave them, say, 300 amio during resuscitation. We get a command order now that we're going to give put the patient on an amiodarone infusion. Amiodarone, I can't talk today, infusions run at 1 milligram a minute. So the amiodarone infusion is going to run 1 milligram a minute, and if you tell somebody an amio drip, that's what they're going to be thinking. So I want to just differentiate that even though we're doing medications on the pump, it doesn't necessarily mean it's an infusion. So for example, we have a newborn with a blood glucose of 30, and we know that they can tolerate lower blood glucoses. 40 is usually our cutoff. So yeah, it's a bad day for us. We see this kid's got a glucose of 30. We're going to need to do something about that. We're going to need to give this kid some D10. So we'll pull out our Hantevi book, we'll take a look at it, and we'll say, all right, we want to give 20 mLs. So we're going to say we're going to give 20 mLs of D10. Is that going to be a drip, or is that a bolus of medication? Even though it's dripping in through the pump, even though we're using the pump to give it, that's still going to be a bolus of medication. It's going to save you some heartache when you get up to the hospital and you try to tell the NICU doctors that you put them on a D10 drip. It'll keep them from losing their mind. It's still a bolus of medication. We have a patient who was in cardiac arrest. We gave them 300 milligrams of amiodarone during cardiac arrest. You got ROSC. You want to start an amiodarone drip, hopefully keep them from going back into a ventricular arrhythmia. You contact medical command, you get an order for an amiodarone drip. You're going to do this at 1 milligram a minute. Is that going to be a bolus, or is that going to be the drip? And that's definitely going to be the drip. That's the infusion. We have a asthmatic. We've gone through, we've done our NEVs, we've given our Medrol. They're still not breaking. We want to consider doing 2 grams of MAG for this asthmatic. We get okay to go ahead and do that. We're running 2 grams of MAG over 20 minutes. We draw that up, put it in our 100 bag. We pull out our pump. Is that going to be a bolus, or is that going to be a infusion? And even though we're diluting it out, we're giving it in through the pump, that's still going to be a bolus of medication. So why does this matter? Why do we care if we're giving a bolus or if we're giving a infusion? There's 2 reasons we want to make this very clear, or 2 reasons we want to delineate between our infusions and our boluses. First is going to be the mode that we use the IV pump for. The IV pumps have a medication library. If you're doing any of your infusions, whenever we're doing an infusion, we generally have a large quantity of medication hanging, and we want a little bit of that medication going to the patient. We know that there's always a possibility of human error, that we can make mistakes. So that's why we have the pumps, so actually have safety checks within them when we're in the medication library. So if you hang that bag of 100 milligrams of cardizem and you accidentally told the pump that you wanted to give that entire bag over 10 minutes, and you're in the medication library, the pump's going to say, no way do we want to give that 100 milligrams of cardizem to that patient over 10 minutes. That would be a bad idea. So there's safety checks set up within the medication library. So anytime we're doing an infusion, an actual infusion of medication, we're setting up a drip that patient's going to be on for a long time, there's probably a lot more medication hanging than we want the patient to get at once. And we want to make sure we always use the medication library in those cases, so we have those safety checks, so we have that safety net in place. If we're doing a certain amount of medication that we say we want this patient to get 2 grams of magnesium, we're just going to put it in a 100 bag, and we're going to run it in over 10 minutes. Because there's so much variation in that, those are not set up in the medication library. You can't really set up the boluses in there. So in those cases, we need to use general mode. And that's what allows us to just put in any numbers and the pump will do it. That's considered safer because we're not hanging a large quantity of medication and letting the pump give it. The amount that we're putting in the bag when we add that 2 grams of magnesium to a 100 bag, we want the patient to get that full 2 grams. So the most error we can make is we might give it a little bit too quick. Whereas we're not going to have to worry about accidentally giving the patient 10 times too much medication. So if you're doing a bolus of medication, you only draw up and put in the bag what you actually want to give the patient, and then you can safely run that in what we call general mode. But if you're doing a true infusion, where you're going to put, hang an entire bottle of nitroglycerin on your patient, you always want to be in the medication library so safeguards are active. The other reason that we want to make sure we're using the right terminology between bolus of medication and an infusion of medication is when we're talking to our medical command doctors. If we have that patient who we talked about, the asthmatic, and we call up and you try to get orders to give this asthmatic mag, and you call up and you might give a great report, everything you've done, here's how sick the patient is, and you say, I want to put this patient on a mag drip. In your mind, I'm going to pull the pump out, we're going to put that mag into a 100 bag and we're going to infuse it in over 20 minutes, you're thinking that's a drip. They're going to be thinking that magnesium drips, those are usually what they put patients on that are inpatient, they're going to be on it for a long period of time, and you're likely to get some confusion or some disconnect there when you're talking to them. If you're trying to say that you want to start the patient on a mag drip, when really what you're trying to do is give the patient a bolus of magnesium. So you can certainly talk to them, get the order to give the patient 2 grams of mag over 20 minutes, and as a paramedic you can say, okay, the safest way I can do that is through the IV pump, and that's fine, but you're still doing a bolus of medication, you're just using the IV pump to give it in a more controlled and safe manner. I hope that clarifies a little bit of the difference between running the medication drips versus the boluses. So now that we talked about what medications we're going to run through our medication library and what medications we're going to run in what we call general mode, let's look at our medication library and how we access that. So once we've completed the priming of our tubing, we'll see this screen here. And we're going to press OK. We get the video to start. There we go. We're going to click New Infusion. I'm going to stop right here real quick. You can see that if we had a larger medication library, you would be able to type in the name of the medication and find it more easily. That's what these numbers and letters are here for. You can see that we only have 5 medications in our library. So the easiest way to do it is click this button down at the bottom right hand corner that says Find. And it brings up our entire library. Nitroglycerin's hanging out on the second page there, but we can go back and forth and access our entire medication library.